Hi, everybody. I know I can't tell if you're there, although I see we got quite a few people here. Good evening. I'm going to let a few people try to gather, but I want to start because we have a lot to cover tonight. But I'll introduce you myself. There are many people I'm looking at the list here that I know, and there are a few people I don't, but my name's Hugh Flax. I'm speaking to you from Atlanta, Georgia. I'm actually looking out of my window and looking at the traffic, and glad I'm sitting here in my office and spending some time with you. It's really a pleasure to be here tonight to chat with you. From the looks of things, it looks like we've got people from all over the world that are attending this. This is just absolutely incredible technology that we can do this. I see there are people from New Zealand, Alaska, Europe, Pakistan, even the good old USA here from Georgia as well. So it looks like we've got people that are just starting their day, and looks like a few other people are just finishing up their day here in the States. Hopefully everybody can grab some coffee and when they're starting their day, and I can wake them up, and hopefully I don't put anybody to sleep here in the States. I am honored that you're here to join me. Hopefully I'm going to be making some contributions to each of you clinically that will make a difference for all of you in your practices. So with further ado, I'm going to go ahead and get started, and let's get rolling here. So let me move this little slide here. And we have some goals for tonight in this presentation. I wanted to share with you. First of all, I'm a regular dentist. I do wet finger dentistry all the time. I see patients about 180 days a year. I write articles, I lecture, I go to a lot of classes, and just like everybody else. And I'm not a researcher. I've pulled out some research here for this presentation so that I can share things that are based on science, because I don't do anything that's not based on science. So what I want to do tonight is share many contemporary considerations for choices we have these days. It's amazing with polymer technology what we can do restoratively and what we can do to merge all those things together. And we're going to talk a little bit about the chemistry that will help increase predictability for you and your patients. And then what I want to do is, after I share the research, I'm going to share some cases of two cements that I've started to work with quite a bit in the last couple months. One of them I've been using for a long time. I'm a big glass ionomer fan for many years, and I've been using Fuji-Sem for a while. And I'm also going to share with you another breakthrough that GC has come up with in terms of cementation. I've been a huge Reliax fan for many years, actually the last 2 years, actually, because I've been going out to the Kois Center and learned quite a bit from John about some of the things that really been able to make a difference for really simplify some of the things that we've done in our practice. And I think that's really what it comes down to these days, is that we need to intellectually simplify things for our staff. And if we can do that and have systems that work, we can get through very, very hectic days and know that our assistants are able to do their jobs, and we're not having to worry about how they mix the zinc phosphate and all the other things that we had to go through many, many moons ago. So just some disclosures. I'm a huge proponent of responsible aesthetics. I'm past president of the AACD. That's where we, Michael Sussman termed that phrase, that we do things as ethically as possible. We're not cutting down teeth, and we're trying to be as additive as possible. I'm a big believer in being leading edge, not bleeding edge. What I mean by that is that when I do procedures. I'm not the first guy buying the new laser or the new bonding materials or something like that. I'm letting other people experiment with those and kind of work out the bugs, and then I'm jumping on the next stop of the bandwagon. The products I use them all the time, and I like to share what's working for me. I'm not a person that you pay me and I'll use your product. I will be very careful about products that I use because I take a lot of pride in the dentistry I use. I'm just very lucky that I've been exposed to a lot of great companies, and GC, who's sponsoring this, was nice enough to pay me an honorary, and I just wanted to be upfront about that. And then the learning I'm sharing is new and reinforcing time-tested knowledge, and I hope that over this evening that we can, you'll hear what I say and we can learn from each other as well. Being from Georgia, and I'm being a music fan, I'm blessed that we have a plethora of great musicians in terms of, musicians as great as Ray Charles, and going through the Allman Brothers and Otis Redding, and then going to Zac Brown and Outkast. So it's a blessing to live in an environment like that. But also, Atlanta is famous for its traffic. Usually you don't see traffic moving this quickly in Atlanta. This is the downtown connector. Usually it's bumper to bumper, which is the reality I have to deal with on a daily basis. But I'm also blessed that I have that these people have been in my life. Of course, the person you see on the left of your screen is Ron Goldstein. He taught a elective my senior year at Emory, and quite an inspiration to me then, and still is now. We still chat every so often when he's not traveling. The people on the upper right of your screen is my team. Actually, we just added another person there, but I like to think of myself as Hugh Flax in the Teeth Street Band. I can't do what I do without them in my office. But the people on the bottom right, I always tip my hat to them, are my family. My daughters and my wife allow me to sit here at night, not only with you, but even on other nights, working on research, working on photography, and different things, so that I can share my time with you. So I know many of you have probably seen this quote or heard this quote before, and I think that probably you have many mentors in your life that you feel that you can stand on their shoulders. Certainly, you may have some from dental school or people that you've seen in CE. I certainly feel like I'm sitting here tonight, standing on the shoulders of, or symbolically at least, standing on the shoulders of people like Pete Dawson, Ron Goldstein, John Coyce, and many others. But at the same time, we go through life, we have to find others that are our mentors. And one of the things I've done over the years, taking advantage of technology, is to watch TED.com. I think there's some really great people on there. And I stumbled upon, I was taking the Implant Maxi course with the AID last year, and I stumbled upon this interesting presentation from a guy named Matt Ridley. He's from Great Britain, and he came up with this presentation, When Ideas Have Sex. Now, I don't want you in the review tonight saying that Dr. Flax was talking about sex in his presentation. That, for sure, I'm not doing that. But the quote that really hit me is that we all get together and we actually synergize together, and we combine and recombine until we eventually come up with newer and greater ideas. I know when I was in dental school, bonding was just getting started. Implants were considered science fiction. Things have really changed quite a bit. And, this is really a metaphor for what we deal with in dentistry. And it's such an amazing profession that we have. And that, truly the people who are sitting on this call, I consider you all leaders in your profession. You believe in innovation, you believe in improving yourselves, and you're not a follower. And we've seen the dental profession move from the stone tools of, let's say, using zinc phosphate or using belt-driven handpieces to the sophistication of using CAD/CAM technology or cone beam and things like that. It's very symbolic by the computer mouse. So it's really exciting to be enjoying that. So what we're going to talk about tonight is about cohesive crown cementation. And what I mean by that, to distinguish this from adhesive, when I talk adhesive, I'm thinking bonding to enamel. One of the things I've learned, and we'll talk a little bit about this tonight, is that I don't put etchant on dentin anymore. I've stopped doing that. Just like I stopped doing amalgams back in 1990, I stopped 2 years ago putting etchant on dentin, and I'll share some reasons why. So we're not going to be, we're talking about crown cementation, and we're talking about how we can take dentin and maximize the strength in that and actually augment the teeth and really biomechanically get some better results for people. So I want to make sure that we understand that. So there are plenty of modes of failure when it comes to crowns. You think about, when it comes to the teeth, there's caries, and then you get the patient complains about tooth sensitivity, or then you get irritation of the gums, or then the restoration, or let's say the car itself. If the teeth is the passenger, the restoration is the car. Well, eventually you can get recurrent decay around that. The cement can fail. Lot of different things can happen, and what my goal is to prevent those things from happening. And the reason why I say that is this cycle. My mom got me into this profession because she went through she was a fearful patient, and she also was very upset about the dental profession. She went through 4 different makeovers, none of them having to do with me, but what she calls the gerbil wheel of dentistry. And there are many places where we can stop this repeated restoration cycle. When we're doing fillings, we can make sure that our bonding protocols are exact, and we can make sure that biomechanically we're strengthening teeth. So what we want to do, and I want to talk about this before we actually talk about technique, is just the risks that are inherent when we're doing crowns, because it is a big deal when we're doing a crown. We're taking away tooth structure from somebody, something that was God-given. It may be irreversibly damaged, but we need to take into account that we're always dealing with caries. It's always in the background, and the classic model is it's a bacterial infection. And I'm not going to belabor that because that's not why we're here tonight. But it's evolved quite a bit through a lot of research. There are quite a few people who are probably on this call that are familiar with the Canberra model, the caries assessment, caries management by risk assessment that came out in California over 10 years ago. And caries is changed a little bit. It's a biofilm that really is acid mediated, and there's many types of bacteria that will cause it. And the old adage, you tell your patient you need to brush, you need to floss now, and then they still have problems. Well, this gives us answers of why people have problems. So when we're looking at problems or doing restorations, we need to be thinking about the risks that we're taking with them, and think about the usual suspects of the genetics, the biofilm, what diet people are using, saliva, the quality, lack of, a lot of people that take medic cause dry mouth, and then the pH that they have in their mouth. And if we take those into consideration, that when we alter the pH alters in their mouth, and it's less than 5, we get a calcium phosphate deprivation from the tooth. Even when there's a crown on that, covering that tooth, is still the dentin can break down underneath there. So we want to do everything we can to create a very positive environment for our patients and raise that pH so that they can people can get positive results. So there are many considerations when it comes to using cements. These are some contemporary things that we think of in terms of, we've always been concerned about micro leakage and plaque, but now we're looking for film thickness. We're looking in terms of, how can we use this for ceramics? How can we use this for metal? And now we have two different ceramics that we can use, lithium disilicate and zirconia. Do we have good working times? Because if we're using a dual cure material, we have to learn to seat them quickly. And then how easy is the cleanup? I mean, the days of struggling to clean up bonding materials, those should be in the past. The chemistry of these materials has gone, light years. And then because we have a very aesthetically generated society, we also want to be considering the choices that we have in shades. So one thing I just want to say is that the cements that we use, no matter what cement we use, it's not how good the cement is, it's how we use the cement. It's the artistry and how we use the cement. So you have to learn these materials yourself. You also have to learn, you have to train your teams to how to use that. I'm going to share with you a simplified way of doing that. And if you want, I'll give you my email later. If you want me to email that chart to you, I'm more than happy to do that. So there are some key factors when it comes to cementation. I reviewed before about Carey's history. We talked a little bit before about prep design. We're not going to be talking about how much enamel that we're retaining right now. We're focusing on dentin. So we're going to focus primarily tonight on the differences between enamel and dentin and just restorative substrate management. So moving right along, obviously everybody knows the difference between enamel and dentin, but to just clarify, just a few things. Dentin has become, I know when I was in school, if you etched dentin, it was, verboten. You were going to some place that's hot beneath the Earth's crust. And but we started etched dentin years ago. What we have found in the research is that it's not as predictable as we thought because of the different types of anatomy in there. We got peritubular dentin that is highly mineralized, but as you get deeper, you got intertubular dentin that the size is variable there, and the closer you get to the pulp chamber, you're not sure what you're going to be getting. And but also there are a lot of problems there with a lot of dentin. You've got you can when you're etching dentin and then you're rinsing it and then you're drying it. Well, how do you dry it? I mean, do you dry it where it's bone dry? Do you dry it where it's moist? That's always been an unpredictable thing. And also, bond degradation has become a huge discussion that MMPs will start to plasticize the composites, and there are different products that we can use to do that, but nevertheless, if you're etching dentin, you're going to be getting changes underneath in your bonding materials. So we want to try and avoid that if we possibly can. And getting back to what I was talking about, there's the total etch rinse protocol, and then there's the self etch protocol. Self etch obviously simplifies things, but it's not as technique sensitive. But there's still some potential for reduced bond strength. So, and then of course there's the third choice of using the selective etch protocol, and that's probably the wisest one, somewhere in the middle between these two. But still, those are things that you still have to take into consideration. So there was a great article, and if anybody here gets on PubMed, it's amazing some of the information that you can find here. And when I'm lecturing, I try to do some research to back up the things I'm saying. And there was an article that came out, it was a very contemporary article that came out late last year, an overview of clinical alternatives to minimize degradation of resin bonds. And like I said before, contemporary bonding is not as durable as has been previously assumed, and there's a trend for using adhesives that are more simplified so that we can get more predictable techniques there, but there could be a potential loss of effectiveness. But there's been some real advancements that they mention in this article, that self-adhesive resins have been developed to use them with, instead of using them with a separate bonding agent, you could just use the cement and place that on the tooth. And these materials are used primarily for cementation of crowns, the cohesive type of procedures, or using them for bridges or inlays and onlays. And the nice things that they're doing is they're taking self-adhesive cements, and they're actually partially filling these, and they've actually improved the mechanical properties, so we have something that's much, much easier to use, and it gives you greater peace of mind. There was another article that came out last year that said that self-adhesive bonds, obviously, as I mentioned, give you a more simplified procedure, and that they're filled there, but they also get greater improved mechanical properties over self-etch bonding agents. One of the things that has been a real help to me in making sure that I get some great results with these bonding agents is to completely cleanse the tooth. I do a lot of laser dentistry. There's some improvement in the dent quality, the crystalline quality, but there's also been some research in how the laser will denature the protein. And I found out about this a few years ago from some of my friends in Japan, that this is a problem. And I did some research on this. I found the Prep Start, and what the Prep Start will do is it will micro-etch the tooth and actually improve the shear bond strength of enamel and dentin as well. So this is something that highly recommend. You can see right here when you do particle abrasion here and here, with all the dentin, you get a superior bond strength there. So certainly something you might want to add to your Christmas list. And it also works when you're using CAD/CAM crowns, which many of you are probably using. A research study that John Kois presented earlier this year had shown that when you're doing lithium disilicate restorations, you want to absolutely be sure that you're using silane. I know this is some old news to some people, but I want to be sure to share that research there. You can just see from looking here, this circled item here, that it practically doubles the bond strength compared to so many other restorations. And then when you're using MDP type of materials, whether the phosphate containing primers, that and I'll correct this, I should have put the circle right over here, that with Monobond Plus and Z Primer, that the bond strengths are just unbelievably better when you're using that with your cements. So these are the two that they recommend and that I have in my office. I tend to use the one from Bisco, the Bisco Porcelain Primer, and when it comes to bonding, I'm using the Bisco Z Prime Plus. They're just really nice products. They're easy to use. Another thing that they have found is that they're able to put priming agents into these cements. So instead of putting the primer into the restorations, they're able to improve the bond strengths and actually simplify this whole process. And we'll see this later on as well. One other thing, that just something else I found in my research that might be helpful. I know I was raised in the days where you had to use rubber dam, and actually I used the Isolite with a lot of the procedures that I do. But it says here in this research that came out this year that it really doesn't matter. As long as you're using really good isolation technique, you don't have to use the rubber dam. So this is the chart I was referring to, and I put this together a few weeks ago for my team. As I was thinking through this presentation, I was thinking, okay, one, how can I teach you, and how can I take this back to my team and share this? So if you want to me to send this slide to you, I'm more than happy to do that. My email address is h.flax@flaxdental.com. You'll see that when we start doing the questions and answers as well. But when I'm thinking about cementation, I'm thinking about two things, okay? What situation am I in terms of low-risk biomechanics? So I mean by that, does someone have a very low pH, or do they have very weak teeth, or they have a history of root canals, and they've had a history of re-decay? I'm going to use something that is a non-bonded restoration in high-risk biomechanics. I'm going to use a glass ionomer. And then when someone has a low risk, I'm going to use a bonded cementation technique. So the first thing to do after you do your treatment, after you do your try-in, you need to treat the restorations. Each restoration has a different way of doing that. With lithium disilicate, you'll treat it with phosphoric acid. You'll rinse it with water, and then apply silane and dry that very thoroughly. And with zirconia, somewhat similar, but you're doing particle abrasion there because you cannot etch the inside of the zirconia, and you only do that for 20 seconds, and then you paint the MDP on there. And then with metal, I go into my lab and I just treat the inside of that with a 50 micron, not a 27 micron aluminum oxide. And then we go ahead and isolate and treat the tooth, and then we do our cementation technique. That keeps it very simple and makes it easy for my team to know what to expect. I don't have to hear, what do we use next, doc, and stuff like that. So there is a new player in the market, as I mentioned before, that I've been using ReliX for a couple of years. Love the product, and I was just hearing some rumors from some friends that were at GC and heard about this product, and I think this is going to be something that's really going to become a huge player in the market. LinkAce is a really nice product to use, and I'll show you why. There was some really great research on this that was done at IADR last year that showed that LinkAce had similar bond strengths to ReliX Unisem, and when you can compare a product or even exceed Unisem, you got a winning product there. And they had done some research with some evaluators. The Dental Product Shopper had done this, and they had found that many people were very pleased with this. They gave it a 4.5 out of 5. It's got high wear resistance. It's very, very easy to use. My staff loves how we do this. They don't have to load it up real difficultly. Excess cement's removed very easily because you do a very quick tack cure. And if you're cementing with zirconia, you don't have to use the monomer at all. So the focus, and these are some slides that GC provided me that you get, when you're doing something that's got a thick material, it's at least a millimeter to a millimeter and a half thickness, that the light's not getting through, so you want a really good self-cure mode. You want a really good durability with zirconia. You want to make sure that those phosphates are working well for you. If you're doing an anterior restoration, you want really great color stability, especially if it's dual cure. You don't want any you don't want any wear around the margins at all, and you certainly want, from a standpoint of seating it and doing a very quick cleanup, you can do that with the 1 to 2 second tack cure there. As I mentioned before, you can't pass light very easily through some of these restorations there, especially with metal, but even with zirconia. So you want something that's giving you a really good, predictable dual cure. And you're looking here comparing ReliX to GC-Sem or Unisem and LinkAce, and it's a very, very solid material there. These are research studies done by GC. I'm looking forward to seeing some done independently as well. As I mentioned, zirconia, you can't etch it at all, so you have to treat it with the MDP. So you want to have something in there. It's so much nicer when you have a product that you don't have to treat it with multiple chemicals. It's just a real hassle for the staff. You're hoping that they do everything, in order. And this is not a knock on anybody's staff. I have terrific assistants there, but when you can do some intellectual simplification and create simple, nice, easy systems to work with, you get predictability. You can focus on the task at hand. The tensile bond strength with GC Linkase is comparable and actually exceeding what you get with Reliax. And the color stability is quite comparable as well. The sequence is, of course, you prepare the teeth, or you clean up the teeth, you acid etch, place your primer in there, and then you place your cement. You seat that on there. You do a quick tack cure. You remove the cement, and then you go ahead and do another cure here that will give us something that will be a long-term cleanup. So very, very simplified system. So I'm going to show you a few cases where I've used the Linkase very nicely. I'm lucky in Atlanta that we have it seems like all highways run to Atlanta, except maybe if you're overseas. But it's a patient of mine that comes from Greenville, South Carolina. She's 70 years old, wanted to do something with her smile. She was told that she needed ortho. To try to do ortho here would have been really difficult. You can see the midline discrepancy. She would have needed surgery to be able to do that. At 70 years old, she really didn't want any part of that. You can see right here, she's also missing her lateral, so we got a canine in the lateral position, which obviously is probably what led to the midline discrepancy. So a very challenging case to do. Biomechanically, we had some issues with teeth that had some root canals, but overall she had a lot of good things going for her. Very solid bone to work with. Really was a pleasure to get started, but we had to get very creative with her case aesthetically. My lab, I use my imaging system, and I actually, when we send out the case for doing the wax up, I send them detailed notes on here's what I'm seeing, here's what I want to correct. Obviously, you can see if this is the interpupillary aesthetic plane, and here's her current aesthetic plane. We had to make some changes here. And, she had a lot of liabilities to deal with. I mean, great woman, great person, but we had a, skeletal dental midline issue, missing the lateral and having the crowding on the lower teeth, and multiple, post and core and crowns to deal with. In terms of just her age, we had determined for her what was really ideal, and also, limited funds. She would have loved to have been able to do everything at once, but we had to come up with a plan that she could stretch her dollar and stretch her time as well. So we came up with a progressive treatment plan that we would treat the upper teeth as ideally as possible, and then with the lower do some transitional bonding, straighten the lower interiors with the Inman aligner, which we're still doing right now. And then once we're complete with the ortho, we'll wax up the lower surfaces and augment those bottom teeth either with crowns or with bonding. So here's the wax up that the lab put together. Using the Shimbashi plane, we wanted to open up her bite so we had a little bit more room to work with in the front, especially if we were eventually going to be doing some orthodontics on the bottom. So I needed to decide what was going to be my plane. So the beauty of using a laser is it allows me to fool Mother Nature, for lack of a better term. And we use the laser to, where you see these black lines, to start creating a more aesthetic plane here. And you can see right here where we wanted to go ahead and just adjust that, so we started creating a better incisal plane as well. So after we adjusted the incisal plane, we adjusted the gum tissue, and we knew this was going to be where we wanted to put the lateral, and this is where we want to put the centrals here. So we're just kind of tweaking or turning her incisal plane and her gingival plane as well. So after I did my gingivectomy, and we did some closed flap bone reduction, we did some laser frosting here, some biostimulation to make that work better here for us. And then to stabilize our occlusion, we used this jig that I had from the wax up, and that helped me set up where our bonding was going to be on the lower. So we used this as our template and cemented that, and then we bonded to the lower, and we established the occlusal plane. So a good start for her. And then we just verified that our Shimbashi was the same, that our vertical dimension of occlusion in the incisal area at the gingival margins, we were verifying that that was matching up with the wax up. And once we were able to do that, we knew we were, I could send her home. So I always send my patients home to let them test drive their smile. I don't immediately go on things because as much as we strive for perfection, our eyes get tired, our bodies get tired, our patients get tired as well. So we let them test drive and give me some feedback on how things look, how they feel. Patient was very pleased with things. She just wanted things to look a little bit brighter. So, but we, and just had a minimal amount of occlusal adjustment that we had to do. So, I'm proud of the fact that my lab, I use Wayne Payne down in St. Clemente, and he and I are both the same philosophy. If I spend the time working through the temporaries with the patients, all he needs to do is match the temporaries. If he matches the temporaries and my patients sign off on the temporaries that they approve them, we'll have our occlusal dimensions taken care of properly, and the aesthetics will take care of themselves. So his job is basically duplicate what I have and build the layering of colors that we want in the restorations. So here we are using the Prep Start to cleanse the teeth. And then I use Conceptus routinely after that to just cleanse any of the aluminum oxide off the teeth there. And then what we're doing is these are Emax restorations that have been treated by the lab, and then we treated them later on with the protocol I gave you in the outline. And you can see how nice this tip is just to be able to paint that in there versus some of the other systems that we had. Is just really just so nice to do. Gives my assistant a lot of precision. She knows these restorations fit like contact lenses, and so she can with a very well controlled injection, we don't have a whole lot to clean up. And here's our patient a few weeks after we placed the restorations. You can see what we had before, and here's what we had after. And a very nice result to get her started on her journey. Eventually, of course, we're going to be replacing these restorations, but she was just ecstatic about the brightness and the symmetry and where the midline was. She knew it wasn't perfect, but as Vince Kokich had done in his research years ago, long as that midline is vertical and long as it's not angled, we can waver 2 to 3 millimeters mesial-distally and still doesn't really catch the layman's eye or a dentist's eye. So you can see here, looking under the hood, how nicely everything blends in there with the gum tissue. We got a really nice blend in here. As part of our treatment planning, these molar temporaries are actually still temporaries here. We're going to put next year, we're going to go ahead and put the permanent restorations in here after we finish doing her Inman treatment. So a really good start with that one particular case. But here's a case that I really, really love. This is a very, very nice patient of mine. She started seeing us a few years ago. Breast cancer survivor, proud University of Georgia grad, and just very, very pretty lady. She'd done some modeling, and unfortunately, with breast cancer, really, took a toll on her emotionally, and she just stopped wanting to smile. You can see right here where her smile is. It's just almost a reverse curve that she's dealing with here, and she just was very, very apprehensive about smiling, very apprehensive about chewing. She was afraid she was going to continue to break her teeth. We put her in a you can see here the x-ray. She's got some very strong teeth, a lot of tooth structure here. And, when you see the wear that she was having in front, many people would say, oh, well, let's go ahead and do a full mouth rehab. You can see where she's getting wear on the bicuspids in here. But I really want to be augmentative with this type of case. So we deprogrammed her and using a Kois deprogrammer, and had her closed down, and we injected where we knew the bite was, and we knew where the hinge axis was, and we had the lab go ahead and wax up this case so we could be augmentative. And the plan was to do Emax onlays and veneers on the bicuspids and canines, and then I would do transitional bonding on 7 through 10 and then 23 through 26. So you can see how we're managing the occlusion here. That's the intended plan here. This is the prep phase. You can see we barely did any restorations, just placed some bevels here for Wayne so we could get a good positive seat here. And then we index the bite. I'm a big believer when I'm doing these full mouth cases of tripoding the bite so we get a real stable mounting, so the lab can get the predictable results we wanted. So you can see here are the restorations on the model. All very, very conservative. So we're doing an additive procedure and placing the Isolite in here. We're treating the teeth very simply with we've already treated the porcelain as specified before, and then we're treating the teeth very simply with the Prep Start, and then rinsing them with a Conceptus, and then we're ready to go ahead and bond there. And I use the translucent Lincase. There are other colors that you can use. My patient wanted to keep things as natural as possible. She didn't want to be too showy. She was just excited to have a greater volume of teeth. So after we placed the restorations, you can see them right here. This was very easy to clean up. We were able to get to the real fun part, was to go ahead and do the bonding there. We do a lot of direct bonding in our practice because a lot of patients can't always do the veneer cases or the crowns, and they need to have something that transitions them to they're at the right place. So here's the before and afters. You can see how much volume we've added to her smile. You can see much greater energy in her smile as well. You can see just how nicely the lengths of these teeth, we're following the aesthetic contours of the lips there. It's very gratifying when you can do this and not have to cut down the teeth at all. You're just, playing with the enamel a little bit, but not penetrating the dentin, and really creating something that's augmentative there. She was, if we did it a full mouth rehab, she was looking at a huge restorative fee, and that's not what she was looking for at all. Not on her budget at all, and just very gratified. It was nice that she sent this letter to me, and she sent it to the lab as well. So it's always fun when we get those kind of things. So again, here's that outline we had before, and we're going to transition from Lincase to Fuji cement. I've been using Fuji SEM products for a number of years. I love Glass Ionomer. I actually hated it for a little while because people were having sensitivity issues, and thankfully GC and even 3M came up with their Relax product that people weren't having sensitivity issues with their teeth. What was nice is that GC realized that there were some strength issues with their product, and they came up with a new improved Fuji-Sem, and the delivery system was improved. I'm going to show you that in just a few minutes here. So, as we mentioned, when we're doing a biomimetic luting cement, we want to have strong retention. We certainly want to have good sealing ability and marginal integrity. With any of these type of situations where you've got a biomechanical risk, you want to have sustained fluoride release. You absolutely do not want to have post-op sensitivity there. And certainly you want to be able to seat these very, very easily as well. Again, some other things that GC was nice enough to provide me, that you want to have something that's moisture tolerant. You don't have to, use a rubber dam there. It's nice when you have something in the back of the mouth that's got the fluoride in it, that you don't have to worry about controlling the humidity quite so much. You want something that has an easy consistency, really, really nice film thickness. You don't have to worry of getting that back pressure like we used to get with, let's say, Duralon and things like that. Very easy cleanup. My staff just love the old Fuji-Sem, but they're loving this as well. And obviously, you want to have long-lasting restorations as well. What's different about this new version of Fuji-Sem is they've taken one of their bonding materials and they've injected that into the product to act as a shock absorber. So they've actually gone from the conventional monomer and created a long chain monomer using their genial flow cement, bonding material, which is great when you've got real small restorations to do and just in the grooves there. They've injected that in, or built that into the cement there, so you're creating even a stronger bond between the glass particles and the resin matrix. And it's really improved the physical properties in terms of the shear bond strength. Comparing it to the old Fuji, you've actually improved things almost 50% according to Dental Advisor. You've also improved the ability to mimic dentin, which is really critical here, and you've improved the ability of the flexural strength and the modulus of elasticity, so that it flexes, but it stays with the dentin instead of the dentin flexing and the cement gives, and then you've got a breakdown in the cement and the crown comes off. That's always been a negative that people have had about glass ionomers. I think GC has done a really great job at addressing that. The compressive strength is really critical, because you want to make sure this the cement flows really nicely, and these are all very comparable to Reliax and products there. And but the other thing is the working and setting time. You don't want to have something setting up on you in the middle of a procedure. That's another definition for a bad day. So you like to have something that's similar, and these are identical to each other, so they haven't taken something that was really great and made it worse. They've kept it comparable. So intuitively, you know how to work with this stuff. Of course, you get a really great fluoride release with this product. It exceeds what you get with Reliax. And in terms of film thickness, as I was mentioned before, it flows really, really nicely. And very comparable to the old GC, and it just sets. When you put it in place, it stays there. It really doesn't go anywhere at all. You want to have something that was radio opaque there, because if you want to make sure that you're getting a real good seal around your prep, and very, very good radio opacity here. So let's show you a couple cases here, and then that's going to allow us a little time for some Q&A here. So here's a case. Actually, it's a friend of mine who unfortunately has been dealing with some periodontal disease and actually having some tooth decay issues. She ended up losing tooth number 14. That's the upper first molar, upper left first molar, for anybody who doesn't use the 1 through 32 system. And after the implant had integrated, we uncovered it and with the laser and took our impression. A little tip, those little compule tops that you tend to throw away, keep those. Put those on top of your impression copings. It comes right through the top. You never have to worry about finding that screw. The screw is protected. It makes it a lot easier to get that open tray impression out of there. So we use an index to get the abutment in place here, which you see right here. This is a titanium abutment that was opaqued, and after we cover the cover screw with a very soft bonding material, I believe in cementing crowns permanently on implants there. We torque them down really well. Implants have become much more predictable. And I know the screw is the shock absorber there, but we're torquing these down pretty high, and knock on wood, so far we're not getting any loosening of the screw. So if there's a problem with the implant, I'm just going to cut the crown out anyways, because it's going to be difficult to take it out unless you're going screw retained. And there's nothing wrong with screw retained, but with the abutment system, you can see where the margin is right here. It's right at the gum line, so I'm not worried about cleanup and getting anything underneath the gum line at all. The last case that I want to show you before we do Q&A is another patient of mine drove down from South Carolina. It's about a 300-400 mile trip for her. Very, very nice lady. Very, very meticulous. She had worked at one of the dental schools, and unfortunately, over the years, she'd acquired quite a few crowns. And unfortunately, it looks like that she had developed her own shade tab in her mouth, the walking shade tab, as we say. And she'd lost a couple of her bicuspids because of decay. It looked like over the years that a lot of the crowns that she had were getting patched up with some reparative dentistry. I'm not sure if that was her choice or was the dentist's recommendation that they did that. She's never let on, and I don't like to get into pot shots with the other dentists. I'd rather deal with the present and not really deal with the past quite so much there. But you can see here she had these edentulous areas. My preference in a lot of these cases is to go ahead and do implant dentistry here. Unfortunately, this doesn't show up very well, and I didn't get a cone beam in here, but the amount of room that I would have needed to place even 3.3 or 3.4 size implants in here, and having a 2 millimeter distance between the two implants and about 2 millimeters in between, we didn't have enough mesial distal space in here. It's amazing how natural teeth develop, and that we can, in 3 to 6 months, we can take an edentulous space and grow a tooth in there. It's something that usually takes 10 years to happen. But you got to deal with the biomechanics and the volume of bone. We just didn't have enough volume of bone to work with here. And my patient understood that the only way we could be able to treat this is to compromise the situation or to do some orthodontics there, and that was not something that was in the cards for her. So we elected to go ahead and do zirconia bridges there, but very carefully work with her on her home care, work with her on building these teeth up and strengthening these teeth properly. So this is the wax up that we use in the lab. Again, we're trying to do one arch at a time, but this is absolutely a full arch case. She understands that. I'll flip back here to the occlusion here. There's really no anatomy on any of these teeth here, so we want to build sharp cusps for her to enjoy in the future. So what we've just done is seated this case recently, and then she's coming back after her jaw relaxes, and we're going to go ahead and build these up with composite so that we can get some stability till she's ready to go ahead and do the bottom. So, anyways, before we do any of these cases, we sedate a lot of our patients, and we want to make sure our patients understand when we're doing these type of techniques that we're putting them in temporaries, what to expect with their temporaries. So we give this document, we make all of our patients read this document ahead of time, so there's no misunderstandings of what to expect with the temporaries. They're a transition to a future look. It's part of that journey there. But I do have some patients that do expect perfection, and if they want perfection, we'll give it to them. But they're going to have to pay an extra price for doing that. So moving right along, this is the matrix that Wayne had provided here, so that, you know, it's one thing to say reduce the teeth. Well, when I have a matrix in here and I can just take a diamond and just very carefully shave that down with the reduction coping, it makes life a whole lot easier instead of guessing what the lab wants us to make. So we prep all these teeth. Again, as I mentioned, we use a tripod bite so everything is dialed in. I like to label these so that the lab knows exactly where to place. I take a picture of it as well so that they know exactly what they should be seeing when they put this on the articulator. And then we went ahead and took some shades. Really, this was incredibly tough to prep this case because we had a lot of subgingival decay to clean up here. It really took a lot of soft tissue management. And thankfully, we were able to get through that and get an impression on her that day. And you can see here's the temporaries that we were able to create a huge difference compared to what she had before. Verified that here with our reduction matrix, and everything fit nicely here. And then here she came back 2 weeks later to see how that looked, and you can see just what a nice full smile. It flows very nicely with her gums. You see a geometric progression from the incisal embrasure here, going from acute angles to oblique angles all the way through, very similar to what Rufinok proposed in his textbook. And what we did was take this picture, and this is a really great picture to take with your patients, that you do a retracted view, full face view, and you can double check. Here's the pupillary line, here's where the incisal edge is. It really helps the lab dial in what we're trying to do. It also, we take a triple tray, anterior triple tray, and the lab creates a matrix here because sometimes there's some fatigue that takes place when we're taking our bite registrations. This also allows the lab to go ahead and fine-tune the bite so that we have a lot less adjusting when we seat the case. Little picture of the lab doing these. These are Emax restorations. On the individual restorations, the bridges are zirconia restorations, and these are all cut back restorations so we can maximize aesthetics. And then here's the case seated on the model. We let our patients see what that looks like. I'll let them view it, and so that they can see that everything matches to the matrix that we created for the temp model. And Wayne just did a really fantastic job with this case. But it's our job to kind of mesh this all together. So you can see the recovery of the papilla in here, nice and healthy. Doing, nice fitting temporaries is just an invaluable thing to the longevity of the case. We make sure our patients go some very thorough aesthetic or hygiene techniques here. We did a little fine-tuning of the incisal edges right here. When patient is, we try this in, patient signs off on this, that they approve the restorations, and then we go ahead and cement. As you can see here with the zirconia bridges, we're treating this with the Prep Start. We also treat the gold crown with that, and then we treat the inside of the zirconia restorations with the Z prime. And the reason why I did that here is, I'm not using the link ace that has the Z prime in it or the MDP in it, but because the link ace now has that additional resin in there, I wanted to just maximize the bondability to the zirconia. So definitely a key step. And then we're treating the Emax restorations here as I mentioned before. This is a really good thing to do. Put this over a cup so that you don't lose them. And then painting the silane in there. And then very simply, we're painting using the Fuji in each of these restorations. What I try to do is start with the front, again with the prep start, cleaning things up, very nice and clean. You don't see any debris right there. And then cleaning that up with Conceptus, placing the Fuji stem in the restoration, and then seating them fully there. This does not move at all. You don't have to worry about any looseness in this. And then we place all four, and what I try to do is place 7 through 10 first, let that set, and then go ahead and clean those off. And then we place the posterior restorations here. And then here we are at the final seating of the restorations. Just, really, really pleased. Eventually, I'm looking forward to seeing her a couple weeks after the first year to see how nicely these papilla come in. But a really nice texture. Wayne really did a great job for us on this case here. So just a little plug here for the ACD. We're having our meeting in Orlando this year, right down the street from Disney World. That may work for some of you. This is just want to mention that everybody on this call has got the tools for greatness, and not only restoratively but also in terms of your practice.